Hello friends, let us now learn about quinsy or peritonsillar abscess. Here quinsy is the collection of pus in the peritonsillar space. See, if this is the tonsil, the space present around the tonsil is peritonsillar space. So in this picture, this is the tonsil. In this picture, this is the tonsil and the space surrounding the tonsil. This space is peritonsillar space. So this peritonsillar space, whenever there is infection or pus which is accumulated in the peritonsillar space, that results in quinsy. So this peritonsillar abscess or quinsy is a complication of acute tonsillitis, though it may arise as de novo without previous history of sore throats. First in quinsy, how does this form? So let us see. So in quinsy, first and foremost we have this is the tonsil, and in the tonsil we have many crypts. Among all these crypts, there is one crypt which is largest. The tonsil on the medial surface has many crypts. One of the crypt is largest and it is called as crypta magna. Whenever there is infection present in the crypta magna, it gets infected, and as a result there is pus accumulation seen in the crypta magna. Then the infection gets sealed off in the crypta magna, which will result in formation of abscess here with the crypts being sealed off, and this results in formation of so-called, we call this as intratonsillar abscess. When the crypt, now if it breaks, if this intratonsillar abscess either at the crypt or at any other site, if this bursts, if this intratonsillar abscess which is like this, now it has burst out, and once it has burst out, the infection or the pus which is present inside the tonsil goes outside the tonsil and it goes through the tonsillar capsule, results in formation of so-called peritonsillar abscess or quinsy. So what are the organisms which are responsible for this quinsy? It is caused by either streptococcus pyogenes or staphylococcal organisms, or anaerobic organisms can result in peritonsillar abscess. Then if you see the clinical features in the peritonsillar abscess, it mostly affects the adults more commonly when compared to children, and it is mostly the acute tonsillitis. If we see, it is more common in adults. Acute tonsillitis is more common in children. Acute tonsillitis is more common in children, but this peritonsillar abscess or quinsy is most commonly seen in adults. This quinsy is most commonly unilateral, and the clinical features are either general clinical features are present, like there will be fever with chills and rigors, malaise, body ache, headache, nausea, constipation. All the septicemic features are seen in quinsy. Along with that, there will be local complications, like one, because of the infection around the tonsil or abscess present around the tonsil, there will be severe pain in the throat. That too, because quinsy is most commonly unilateral, this pain in the throat is also unilateral, and there is pain on swallowing, which is odynophagia is seen. And here the patient has, enlarged tonsil. I will draw the similar thing here. Normally this is how the tonsil will be, right? These are the two tonsils, and this is the uvula. But now in paratonsillar abscess, that is in quinsy, the tonsillar there is pus accumulation around the tonsil, and as a result this will enlarge a lot and push the uvula to the opposite side. So if you see here, it looks somewhat like this. This is the enlarged tonsil, and the uvula which is there, it is pushed to the opposite side like this. Okay, so here if you see this picture, here this is the enlarged this is the tonsil, and this is the quinsy, that is enlarged pus. Because of the pus around the tonsil, the tonsillar space is enlarged, and this will result in the deviation of uvula to the opposite side. This is uvula which is deviated to the opposite side. Now along with that, this will also result in difficulty in speech. So there is a voice which is seen called as hot potato voice is seen, which is muffled or thick speech resulting in hot potato voice is seen, and the patient presents with foul breath, sepsis in the oral cavity, poor hygiene. This infection can spread to middle ear resulting in earache, and sometimes there is trismus can be seen. Then if you inspect on examination, you can see the tonsil and the pillars and the soft palate of the involved side are congested and swollen. Tonsil is not enlarged, but only the tonsillar pillars are mainly edematous and enlarged. Even the uvula is enlarged, swollen, edematous, and it is pushed to the opposite side. You will also see sometimes the bulging of the soft palate and also the anterior pillar over the tonsil. We can see cervical lymphadenopathy can be seen, especially the especially if you see the jugulodigastric lymph nodes are enlarged. Jugulodigastric lymph nodes are enlarged in these patients, and they will try to keep the neck to be tilted to one side, especially to the side of the abscess. So neck is tilted to side of the abscess is seen. This is called as torticollis. And if you see the treatment of quinsy, you should hospitalize the person first and foremost, and because there is a chances of dehydration, we should give IV fluids to the patient, and as it is caused by an infection, you should give antibiotics. As it is very painful condition, we give analgesics like paracetamol to relieve the pain, and you have to maintain oral hygiene to prevent the spread of infection to other places, other sites. Most important is we should do incision and drainage of abscess should be done. Where do you open the abscess? See, this abscess will have one maximum bulge, point of maximum bulge will be there. The site at which there is point of maximum bulge, over there you should give an incision over the maximum bulge or lateral to the junction of anterior pillar or the base of the uvula. If you can find the maximum bulge, then fine and good, you can give it over there. If you could not find the maximum bulge, then at the point of junction of anterior pillar and the base of the uvula, this is uvula, base of the uvula and anterior pillar, at the junction you will give a vertical incision and you will drain the abscess. First and foremost, immediately you will drain the abscess, and you can do interval tonsillectomy can be done to prevent again reinfection of tonsils. This interval tonsillectomy is done 4 to 6 weeks after quinsy. After dissolution or after resolving quinsy, within 4 to 6 weeks we can do the interval tonsillectomy. Then we also have a procedure which is called as hot tonsillectomy or abscess tonsillectomy. This is preferred by some people instead of drainage and incision and drainage. In abscess tonsillectomy, you will remove the tonsils along with the abscess. You will drain the abscess and also remove the tonsil simultaneously. But here the main problem in this abscess or hot tonsillectomy is there can be rupture of the abscess during anesthesia, and if there can be rupture of the abscess during anesthesia, and this can result in increased or excessive bleeding can be seen in hot or abscess tonsillectomy. So we do not prefer it generally. So if you see the complications of quinsy, this quinsy is actually rare with modern therapy. Quinsy is common, but the complications due to quinsy are rare. The complications which occur due to quinsy are rare. So in the complications, see the infection which is present around the tonsillar space, this tonsillar space, this is the quinsy, right? So this infection can spread into the pharynx and it can cause parapharyngeal abscess, right? Then this can also spread into the larynx and it can cause edema of larynx. The infection can spread to the blood and result in various infections causing septicemia. Sometimes it can spread into the lungs causing either lung abscess or it can also cause pneumonitis. Then sometimes it can spread to jugular vein causing jugular vein thrombosis, or it can even spread to carotid artery also. If it spreads to carotid artery or jugular vein, in carotid artery or jugular vein thrombosis, there is increased risk of bleeding which is seen due to quinsy. So thank you guys for watching my lecture. Thank you.